Okay, perfect. So thanks everyone for jumping on. I'll probably only do this for about 20 minutes today, but for those that follow along, those that are familiar with the channel, my name is Chet Donnelly. I'm a spine surgeon here in Dallas, Texas, and I jump on these YouTube lives maybe for 20 minutes, 30 minutes at a time, kind of answer different questions. So let's just get right to it. Today, the thing I want to focus on is technology and spine surgery. And the thing I'm going to highlight a lot today is just try to do a lot of questions and answers. I haven't jumped on one of these in maybe a month or two or so. It's just been a busy time of year. Fourth quarter, everyone has deductibles, Christmas shopping, Thanksgiving shopping. I'm busy, you're busy. So I haven't done one of these in a little while, but let's just get right to it. The two things when I think about technology and why it's important, I think the biggest role of technology in 2026, the next year coming up, is to have patients recover faster. And what that means to me is they use less post-operative narcotics. Narcotics are fine, they're good, they're needed, but if we can decrease the narcotic use, if we can get them up and walking faster, if I can get a patient returning to their job faster, if I can get a patient healing from the surgery faster, then that's kind of the most important part of surgery in general and spine care in general. Look, are there non-operative things to talk about in terms of technology? Yeah, but those are a little boring in terms of doing the live sessions. So I'm just kind of focus some on the surgical aspects. So here's kind of the three things that I focus on in terms of technology. Technology is a big word. One of them is the preoperative modalities before surgery. And this is going to be a really long and boring talk, so I'll kind of summarize what that means. This is the medications that I assign to you that you're taking in the preoperative holding area before surgery. It's an anti-inflammatory, believe it or not, a muscle relaxer, a nausea medication. It's some IV Tylenol. These are things that we do before you even go under to help your body get ready for that surgery. The other thing that we as spine surgeons, and me in particular, me and one of my buddies, we've been really focusing our research on is doing some preoperative nutrition. I've personally gotten really into, I don't know about really into, fine, like daily protein, nutrition, vitamins, stuff like that. But I kind of think like, dude, why do my patients not do the same thing? Like if they have a surgery coming up in a month, should they be taking a protein shake once or twice a day before surgery to really boost their metabolism prior, to boost their anabolic composition prior? And the answer is yes. Is there post-operative and then even preoperative vitamins that have vitamin D and calcium to really strengthen the bone quality to help the fusion potential? Now, majority of surgeries I do aren't fusions, but still always good to do before surgery to after surgery. So sometimes we think of technology, we think of robots, lasers, minimally invasive. But I think one of the things I'm going to really be focusing on next year in 2026 are the month leading up to surgery and the month after surgery in terms of the technology or medications, not narcotics, but supplements that I can be helping my patients find, acquire, and those can help hopefully decrease wound infection, increase bone stabilization, as well as increase muscle strengthening. So those are some big deals and things that I think about in terms of technology that I want to be focusing on in the coming years, particularly next year. The next aspect in terms of technology, when we talk about spine surgeon technology, is this term minimally invasive. And the thing I'll tell my patients if they ever ask me, do you do minimally invasive surgery? I will, it depends on my rapport with them. Usually I say yes, but sometimes I say it's just a marketing term. And the only reason I'm blunt about that is the people that watch these lives know that I'm relatively blunt. I'm pretty darn honest and straightforward. There's no true definition of minimally invasive spine surgery. And so I sometimes encourage patients to ask their spine surgeon what that means. One of the most famous spine surgeons in the world, who was my boss, and I light a candle for him every night, I think so highly of him, but he would jokingly say, look, the guy right across the street, his incision's this big, and so then my boss, his incision's this big. So that's minimally invasive compared to that guy. Now, it's totally a joke, although he'd tell you it's not. But when I think of minimally invasive and having technology, the things I'm thinking about is how I can put in these pedicle screws right here, just like these, with the most minimal tissue disruption. So if you get a spine fusion, you have something like this. It's a pedicle screw that goes in there. You get two of them. This is probably a better model to show you. You get at least two, usually it's four, one on each side, or two on each side, two of these on each side. So 4 screws. Get pedicle screw and a rod connecting. This would be a 1-level spinal fusion, so it'd be, but you got to get these in. Now, sometimes people are like, oh man, I can feel those, they're under the skin. Unless you're like a super thin 80-year-old lady, you're not going to feel these. You have your muscle that goes over it, fat, and then skin. It's really buried down there. Now, you at home might be looking at this side being like, what the heck is that? I'm definitely going to feel that. This is just how I minimally invasive place them. So it goes like this. It's on I don't have the whole holster and adapter, but it's almost on this big, long handle. Through the tissue, I make a small slit incision. I have a lot of patients in this chat room. They can even verify for me. And the incision for real is probably, if this is a writing utensil, the size of this part of the pin right here. Just this part of the pin. I don't need to see everything with my own eyes because I do a CT spin. And then I have this navigation, and then I put on this helmet just like our fighter pilots wear, and I have augmented reality, almost like heads-up display. When you're driving your car and it says the speed, and you kind of look around with your car, that's exactly what I'm using in surgery. So when I talk about surgery of the future, it's that. Now look, we've had that for about a year or two now, but like the new headsets, the next generation, it's like flat screen TVs. When those first came out, they're expensive, big and bulky, and not everyone had one. Nowadays, I would reckon most people at home have a flat screen TV because they're more mass produced. The technology is around to where it's easier to use. And that's great for other spine surgeons also. Other spine surgeons in different communities that didn't have this technology initially, maybe they'll have access to it also. So I put it on this big cannula. I make a small slit incision in the skin. For real, it's about that big. I'm going to need to take a picture one day of a patient and put it right up to it, and then I'll show you guys. Maybe I'll do that this week in the office. Through the tissue, through the skin, through the muscle, I just tease it out to the side, just make a little split in it, little rinse in it, and I place this little pedicle screw right through the bone. And so this is kind of what it looks like. When you put 2 of them in, just like this, then I put a rod down the cannula of them, and then I don't have the tool, nor am I going to do it here on this live, but I break off this tower, and then underneath, you're left with this. Buried under all the muscle, all the tissue, all the fat, all the skin are these pedicle screws. So when I say minimally invasive spine surgery, that's what I'm referring to. I'm referring to making small incisions. And why does that matter? Because that's what hurts. The smaller the incision in general, the less the surgery should hurt, the less narcotics, the faster return to work. Those are big deals to me. This is the town I grew up in, Dallas. My family grew up here. My wife's family grew up here. My wife's from here. And so, I want a good reputation. I want patients to do well. If I don't think you're going to do well, then I'm not going to offer you surgery, or I'm going to tell you I don't think you're going to do well, you shouldn't do surgery. Pretty easy. So recapping, the first thing we're going to try in terms of technology for next year, the thing we're going to do is focus on preoperative optimization in terms of nutrition, bone quality. I'm going to start working on helping my patients get to different third-party affiliates that offer like protein shakes. I tell patients all the time, without great direction, I'm like, you should go to GNC and do some like the mass building, some protein powder. Well, that's very vague, and maybe they do it, maybe they don't. What I'm going to be focusing on next year is maybe like giving them a QR code and be like, look, here's the website you should go to. If you don't, fine, but why not? You're about to undergo a battle. One of the most famous spine surgeons in Miami, that's what he tells his patients. You're about to go to war in your own body. You're going to have trauma to your body. You need to heal it well. So if you know that's going to happen, if you're eating normal, fast food meals or whatever you're eating, why not strengthen your metabolism? Why not eat better food, protein going into your battle and after your battle? And that's what I'm going to focus on. 2, more of these minimally invasive technologies. The new headsets are coming out. Finding new ways to fix big issues with smaller incisions is a big deal. And the other thing that's really important to us is the treatment of spondylolisthesis. Big fancy word of this bone sliding back and forth. So let me take a couple questions here. I see one question that just really stands out to me. It says, I'm in Flower Mound, Texas. I wish I could come to you. I'm in Dallas, Texas, specifically Addison and Plano. Those are about 4 minutes away from Flower Mound. So that's great. Thank you for not trying to sell me Christmas presents. That's kind of funny. Yeah. I'm also interested if anyone has a good Christmas presents idea for brother-in-laws and sister-in-laws. That's what I still need to get stuff for, but we can talk about that stuff later. I'm good on wife, good on parents. Hello. Fusion can cause idiopathic cranial hypertension? No, probably not. Are you familiar with Chiari? Tequila. That's actually a really funny gift, actually. That's actually a really good idea. I actually might do that. Actually, I'm going to do that for my brother-in-law. Sold. Good job. I took a hard impact from a helmet. I don't know what that means. I'm having spinal reconstruction surgery in spring. Great. How do you feel about spine fusion surgery? John, that's a good question. I would think of spine fusion surgery as, how do I feel about someone taking their car to the car shop? I don't know. Fine. Sometimes it's fantastic. Sometimes you really need it. And sometimes, and the majority of times, your car does great. It needed it. It got better. Are there sometimes you take your car to the shop and it doesn't get better? For sure. I would think of spine fusion like that. You can type into Google, because it's a hot thing to type in, 50-50. That's stupid. It's not a 50-50. It's closer to like 93%, 90 to 7%. Because when you talk about fusion, are you talking about a 1-level neck fusion? Are you talking about a 10-level lumbar fusion? And so to put all those in the same category is dumb. It's just not accurate. If you're talking about the success rate on a 1 to 2 level or 1 to 2 level neck fusion from the front, extraordinarily high. And then it's like, well, how do you find success? Getting the symptoms resolved, a moderate to minimal amount of pain post-operative. I mean, if you have a lot of pain post-operative, that's not great, but it goes away. Treating the issue at the 6-week, 3-month, 6-month interval, that's how to find success. What if you get a blood clot in surgery or after surgery? Is that a failure of surgery? Does that make your stat not be 100% successful? I don't know. I mean, blood clots aren't great at all, but if they happen, it's in about 3% of surgeries. I don't know if I consider your surgery a failure. It's just a medical thing that pops up. So sometimes when I hear about patients say it's 50-50, I'm kind of like, what does that mean to you? What do you think is the problem with surgery if it was 50-50? It's just not. A 1-level neck fusion, the success rates are beyond 95%. A 1-level disc replacement in the neck, 2-level disc replacement in the neck, greater than 95%. A 1-level fusion in the back, well, it also depends. Are you going through the front, the back? It's just not totally accurate. So that's why I say it's like bringing your car to the shop. How old was your car? What was the issue? Did your car roll over on the toll road, catch on fire, and you're bringing it to the shop being like, please fix it? Well, that's going to be a pretty tough fix, right? But if it's like your axles of your car, I know nothing about cars, axles of your car are out and they just need to fix that and your car is kind of, in good shape, then that's great and you'll do wonderful. All right, so let me get to a couple other spine surgery questions here. I see a lot of common followers, and it's great. Coming to you for surgery at the end of January, suggestions for the supplements and protein. I'm working on that. I have a third-party website I can send you now. I don't know how to send it on this. It's called, what's it called? I think it's called like Shop. If you just direct message me on TikTok or Instagram or even Facebook, I can send you the website. I totally can't remember off the top of my head. I think it's called like Shop Nutrition. But yep, that's something we're focusing on. Other question here is, what do you think about pedicle screws? These are the pedicle screws. We kind of talked about that here just not too long ago, so I'm not going to bore everyone who's already been watching about pedicle screw fixation. Someone tell me, what is an ALIF, an ALIF? ALIF, it goes bone, disc, and ALIF is the cage that goes in the front. From Humble Guy, how do I connect? I tried Googling your full name. Only sites like Yelp, US News, and Doximity come up. Well, I don't know. I think if you Googled my name, my website should come up. I mean, if you pulled up all those things, that's a good way to connect, honestly. I feel like you found me on 3 different sites. But my personal website, I don't want to do a plug for myself here, but since you asked, is Donnelly. So my last name, it's in what you're watching right now, spine.com. And that should help you connect to our group. And if you reach out to me on any of the social media platforms, I have a third party that kind of helps respond to those and connects you with our group. So a question I am pretty interested in is from McNamara 9048. How would you treat grade 2 spondylolisthesis? So if it goes bone disc, this would be grade 1. Grade 2 is when it gets to about 25 to 50%. And you can have this from a fracture. There's 6 types, but it's either from a fracture or from severe arthritis where it's moving forward. I would treat it by first getting x-rays and MRI. I want to see the stability of it. I want to see if it's moving when you bend forward and bend not. If it doesn't, I might consider just a laminectomy. If it was grade 1 and stable, I'd definitely consider just a laminectomy. Grade 2, let me see. Grade 2 is a little less likely, but still possible to fix without doing a fusion. So let me say that one more time. If it's grade 2, usually it'd probably do better from a fusion. But if it's stable, If it's like barely grade 2, you might still get away with an ultrasonic decompression. Well, if I was to do a fusion, how would I do it? It depends on the level. If it was at L5S1, I'd do an ALIF going through the belly. Fantastic. We just did 4 of those on Friday. That's a big deal. Some people might do 4 of them all year. We did 4 of them just on Friday. And then pedicle screws in the back. If it was at 4 or 5, I might do that. I might go through the side. If it was at 2, 3, or 3, 4, I'd very likely go through the side and then through the back. The side is a lateral surgery when I say through the side. A couple questions. Someone's asking about doctor in Jacksonville, Florida. I don't know that gentleman in Jacksonville, Florida. I apologize. Can you talk about lumbar disc replacements versus fusions? I can't on the cervical spine. I get so bored on talking on it on the neck. Or sorry, on the lumbar spine. Let me come back to that later on. In general, I'm not totally against lumbar disc replacements. I don't love them. 2 of my partners like them a lot. So if I think someone really would benefit from it, I just send it to them. But the overwhelming majority of patients that reach out to me from across the world or even across Texas looking for it aren't candidates for it. They either have huge divots in their bone, they have osteopenia, they have severe disc collapse already, they have terrible back pain, they have instability, the bone slipping. And so it's something where it's pretty easy for me to be like, yeah, I live in Dallas. There's a lot of spine surgeons here that do the surgery. If you ask enough people, I'm sure you'll find someone to say yes to your request, but maybe it's not the best request. Do you advise running after an L5S1 fusion? I don't say like go become a runner because you had it, but if you're like die hard on running, then sure, that's no problem. I don't care if you go running after a surgery. I usually say wait like 3 months, 6 months, 9 months. But I always tell patients, look, if you had a fusion at 5'1", and it's from the bones getting beaten down over and over, maybe you're at the age or time now where you don't run as much. Maybe do, I know these aren't as fun, but rowing, stationary biking, swimming, not as easy to do as just going outside and running, but things to think about in terms of, you already had the wear and tear. Is running the thing that caused your 5'1" to wear out? No, but it's important. It's important to think about just maybe changing things. What's a slight rightward lumbar tilt spine? I don't know. Doing this, I think. Question. Thank you for answering the questions for sure. Do you do online consultations? I am from Canada and need a second decompression. I don't, unfortunately, for the most part, take patients from Canada. I apologize. We don't do Canada. There's just too difficult getting all your stuff because you guys, because of socialized medicine, it's the long answer short. Surgery cap at home. Yep, it's because I was just outside of my backyard playing hockey with my 7-year-old, so I'm sweaty, and I don't want to fix my hair, so I throw a surgery cap on, and it makes me look a little more legit and official. So, yeah, I'm obviously, I'm in a t-shirt and a vest, so I threw my white coat on. Really, the white coat should throw you off more than the scrub cap, but it's 4:30 in Dallas, and watching college football earlier today, or pro football, so the scrub cap's just for show. Are there any grade of spondylolisthesis you wouldn't do surgery for? No. I mean, if it's grade, there's 5 types, or 5 grades, 1, 2, 3, 4, 5. That's like when it's falling off. It's not. There's never a case where it's so bad you wouldn't do surgery. It's more so if like the patient was a surgical candidate, if they weren't doing that bad. There's plenty of patients I see where they have terrible spondylolisthesis radiographically, and maybe their back hurts them every now and then, but I'm like, well, look, don't do surgery yet. If you're doing okay, then hold off on surgery. So it's not the grade. Truthfully, the overwhelming majority, I don't know the stat. I'm sure ChatGPT would know. I would guess it's like 90% are either a grade 1 or a grade 2. Grade 3 and grade 4 in general is reserved actually for teenagers or people that were born with spondylolisthesis, and it really just dislocated in your, well, kind of who knows, but usually it's in your teens, adolescents. And those are actually people who have the really high grade slips, the grade 4s and 5s. And so you actually don't always want to reduce those. In fact, if it's like a grade 5 or even a grade 4, sometimes you just fuse them in place. It's actually, I wouldn't say controversial, bad, but debated. It's all risk benefit. In fact, reducing that bone back all the way could definitely result in an L5 nerve injury. So a lot to be talked about there. Great question there. I had a laminectomy from one of the people who just commented. A laminectomy is probably the number 1 most common surgeries I do. I'd assume most surgeons it's the most common. The way I do it is a small incision. There's a writing utensil. I'd say probably about the size. I usually say it's like the between the short and the long size of a credit card. So it could be that big, could be that big. Just depends on how many levels. Is it one level? Is it 3 levels? And I use this ultrasonic device. Actually, I have it right here. They gave me an extra one. So in terms of my props at home, this is the hook that I use. This one's from, I don't want to say the name because I don't want to give any marketing to any of them. But this is one I consider the gold standard in them. I've used a couple of them. This one's the best one without, and I'm not even saying the name. So it starts with an M. How about that? And pretty much it vibrates in ultrasonic high frequency and helps melt the bone. And so I tell patients, it's almost like if you have the roof of your house and you're taking a slit out of the roof. From Blast, are you going to Turkey next year? I love that comment. Probably not going to do Turkey. I would stay in the States. I've decided stay in Dallas. I'm not totally sure if I want to do it anymore. I go back and forth. If you have experience with it, direct message me. I'd love to talk to you about that. My anesthesiologist is going, and we were always partners in it. We were going to go together, and he's jokingly mad at me that I'm not going to do it anymore. But I don't know. Now I feel like I'm doing okay. Are there 3-level disc replacements recommended? I used to say all the time I don't believe in 3-level disc replacements, but then I've actually done 1 or 2 of them, and it's just a very unique pathology. And part of it is just hard getting it approved by insurance. They won't, so you have to cash pay. It's just a whole mess, and I don't like it. It's tough on patients. I'll do it for sure, but it's just rare that someone actually needs a 3-level, because usually if you have 3 levels that have worn out so bad, usually you're bone on bone, and if that's the case, you probably need a fusion, or you have instability, or you're super old and you have a lot of neck pain. And so doing a 3-level disc replacement might not be indicated. But I had one guy, he's not too far out, and it really was a case. I showed it to a bunch of people, and they're like, yeah, that actually could be a good 3-level case. It's a rare one for sure. Simplified disc replacements, any experience with that? Yeah, I'd say that's my go-to. I like Simplify and Pro Disc a lot. I've used Mobi-C. I've used others. I use Simplify the majority of my disc arthroplasties. I use Pro Disc also. Truthfully, there's not any that are currently being used that are superior than the others based on any statistics. What is a laminectomy from Handy? Handy's asking that. Honestly, I'd just go on YouTube, type in my last name and laminectomy. I have a full video on that, and that'd probably be the best. What are your thoughts on neuromodulation for chronic low back pain? I don't hate it. I'd say try spinal cord stimulator first to see. That's not invasive. It's actually somewhat invasive. Truthfully, I don't love spinal cord stimulators, but I'm biased, and I recognize my bias. I only see patients that have them and don't do well. Like if you had a spinal cord stimulator and you did well, then why would you be seeing a spine surgeon? All right, everyone. So on that note, I've been doing this for about 20 minutes. I do have to go check on the fam. I can kind of see them inside over there, but I just wanted to jump in and go from there. Someone's asking how long is surgery. It can vary. I'd say most that are like 2 hours. Some surgeries I do are an hour. Some are like 4 hours. You kind of just go all over the place. It's just, I'm making this up. I probably do 9 different type of surgeries over and over. So it just varies on what the surgery is. Is surgery dangerous? Yeah, for sure. It's a big deal. Surgery is a big deal. So we go from the, do I eat red meat? Yes. I don't know what that means. From Daniel asking about the tequila again. That's a good idea. I'm going to do that for sure. Because also, well, I'm not going to say it on a recorded line, but that's a good idea. How common is lateral spondylolisthesis? Not super rare. It's just another type of it. Are there any specialists for femurs and 23-year-old patients? Maybe. I don't know what that means. Are there any specialists for femurs? I don't know. Weird question to end on. So that note, look, please subscribe, guys. I think there's a way you can turn on alerts. I usually jump on these lives on Saturdays and Sundays. I haven't done it in a good while. I actually don't think I'll do it next weekend. I think the weekend after is the weekend after Christmas. So we'll see when I jump back on it. I used to be pretty consistent, but it's a busy time of year, and my kids are fun, and we don't have downtime too much to do these. So I'll jump on again at some other point. You can always direct message me. I think the best way is Instagram or TikTok. Just search my name, and we can send you a way to get a telemedicine set up. The number one thing potential patients don't have are x-rays. Everyone has their MRI, but I need x-rays. Every now and then people get really bent out of shape that I want x-rays also. But the MRI, you're laying down. It just shows me what your body looks like when you're laying down in one image. X-rays are critical. I want to see what your hips look like. I want to see what the structure looks like straight on, leaning forward, leaning back. I want to see the bone quality. And so people that don't have x-rays and want to talk, I'm not making the most use of your time and money. So X-rays and MRI. Yet you got to go back to that spine surgeon's office and have them put it on a CD. If they tell you they can't burn a CD, tell them that a spine surgeon said he had Napster back in the 90s and he was able to burn CDs and mixtapes like, 20, 30 years ago. So figure it out. We can burn CDs. It's not hard to do. Don't listen to people who say they can't burn CDs. We've been doing that for decades. All right, everyone. Thanks for jumping on. I'll talk to y'all later.